Human upper extremities evolved for dexterity, prehension, and reach. They are biomechanically unsuited to serve as primary weight-bearing joints. Yet, for patients with a spinal cord injury, or SCI, relying on a manual wheelchair forces the arms to completely assume the role of the legs for daily mobility, personal care, and transfers. The kinetic loads generated during these routine movements are massive. During a standard wheelchair transfer, intra-articular pressures in the upper joints frequently exceed normal physiological limits by more than twofold. This constant mechanical stress has an established clinical baseline. Between 30 and 73% of manual wheelchair users with SCI report experiencing chronic musculoskeletal pain in their upper extremities. But standard rehabilitation protocols generally wait for patients to report that pain before initiating intervention. Waiting for symptom onset guarantees that structural damage has already occurred. The 2025 cross-sectional study by Tazell et al. Challenges the reliance on symptom-based diagnosis in SCI rehabilitation protocols. The researchers evaluated 38 manual wheelchair users with traumatic SCI. They assessed the patient's wrists, elbows, and shoulders using both standard clinical symptom checks and high-resolution musculoskeletal ultrasonography, or USG. USG is a medical imaging technique that uses high-frequency sound waves to visualize tendons, muscles, and nerves in real time. To definitively diagnose an overuse syndrome, the study required the presence of at least 2 out of 3 specific indicators: patient-reported symptoms, positive findings on clinical provocative physical tests, and direct sonographic evidence of tissue damage. The results showed that clinical examinations based on patient-reported pain consistently underdiagnosed the true prevalence of tissue failure found in the imaging data. Relying on pain as a diagnostic metric leaves structural decay undetected, necessitating a shift toward proactive imaging. This chart compares reported pain against USG-detected pathologies. For the hand and wrist, 18.4% reported pain, while sonographic data revealed much higher rates of structural neuropathies. Similarly, only 15.8% felt elbow pain, but lateral epicondylitis was physically present in 21%. Across every evaluated region of the upper extremity, pathological joint findings were more frequent than the pain reported by the patient. This suggests that the asymptomatic, silent phase of these overuse syndromes represents a larger portion of the clinical picture than standard physical medicine assumes. The shoulder proved to be the most vulnerable joint in the entire kinetic chain. Including overlapping pathologies, 58% of the study's patients exhibited an overuse syndrome in this region. The shoulder is susceptible due to its anatomy. Relying heavily on soft tissues rather than deep bone sockets, the shoulder is poorly equipped for the massive pressures of daily wheelchair propulsion and transfers. Subacromial bursitis, or inflammation of the fluid-filled sac that reduces friction in the shoulder, was the most common pathology. Ultrasound detected it in over 60% of patients, often without the patient feeling any discomfort. This ultrasound reveals acromioclavicular joint degeneration, found in 53% of patients. In pain A, arrowheads point to cortical irregularities, where the collarbone meets the shoulder blade. In pain B, thick white arrows highlight dark hypoechoic fluid collections, signaling stress distending the joint capsule. The study's multivariate analysis demonstrated that while shoulder pain is a strong predictor for rotator cuff tendinitis, increasing the odds by a factor of 116, many other severe shoulder pathologies remain clinically silent. Because the shoulder acts as the primary engine for wheelchair mobility, structural decay in this joint directly threatens the patient's long-term independence. Moving distally down the arm, the elbow joint absorbs immense shear stress. The repeated pronation of the forearm and extension of the elbow during wheelchair propulsion places a heavy load on the surrounding tissues. While conditions like lateral epicondylitis can be reliably predicted by a patient experiencing pain during resisted wrist extension, other distal conditions are more difficult to diagnose through physical examination alone. Cubital tunnel syndrome and medial epicondylitis are examples of distal pathologies that were not reliably predicted by patient-reported pain in this cohort. This sonogram shows cubital tunnel syndrome. On the right is the baseline appearance of a normal ulnar nerve. On the left, the white arrow indicates the neuropathy, a swollen, hypoechoic ulnar nerve with a visibly increased cross-sectional area trapped within the tunnel. Because these distal neuropathies are identified by pathological sonographic findings rather than pain, physical exams alone will miss them until nerve damage degrades motor function. Paraplegia does not load the arms equally across all patients. The risk of these injuries depends on the specific physiological profile of the individual. This model compares a critical biomechanical variable, the patient's level of spinal cord injury. The model on the left represents a lumbar lesion with active core musculature, while the model on the right represents a thoracic lesion with an inactive core. In a thoracic lesion, the impairment of the abdominal and erector spinae muscles eliminates trunk stabilization. This forces the upper limbs to compensate, bearing unbalanced loads during transfers and mobility. The logistic regression data confirms the impact of this lack of core stability. Patients with thoracic-level injuries have an odds ratio of 12.0 for developing overuse syndromes. An odds ratio is a statistic that measures the strength of association between two events, meaning thoracic patients in this study were 12 times more likely to develop these syndromes. A patient's neurological injury level is just as important as their daily wheelchair activity level in predicting mechanical joint failure. The data indicates that in SCI wheelchair users, the absence of pain does not equal the absence of joint pathology. This creates a new mandate for clinical practice. High-risk patients, particularly those with thoracic-level lesions, require proactive, routine sonographic screening of the entire locomotor chain. Early ultrasound detection allows clinicians to implement preventative corrections, such as adjusting push-up techniques, optimizing transfer mechanics, or prescribing supportive splints before tissue ruptures. Integrating point-of-care ultrasound evolves rehabilitation from the reactive management of pain into the proactive preservation of a patient's mobility and independence.